All right, guys, welcome to Cosi Talks Live. I have a very special guest with me tonight, Dr. James Flint. And tonight is our Veterans Day tribute for the Cosi Talks Live show. So we're going to give you guys a couple of minutes to jump on board. In the meantime, I'm going to try to see if Instagram decides it wants to cooperate and let us go live without a hitch. And we're in business. Yay. Okay, so we've got Instagram, we've got Facebook, and we've got YouTube. All right, Dr. Flint, where are you right now? Because you're definitely not on the East Coast.
Yep, San Diego, California. I would
Very
say
nice.
sunny San Diego, but maybe it's a little overcast. But it's beautiful. Weather's not as bad as other places I could be right now.
Yeah. Well, in Tampa, we're back to just being our normal hot, humid, sticky selves over here, and waters are slowly receding from those, little squalls that we had a couple of weeks back.
Hope everybody's faring okay. We were just in North Carolina recently, so we're kind of checking in on the storm damage up there. And luckily, our family was fine, but crazy.
All right, so we got a couple people starting to jump on board. It's Kim coming in from the YouTube channel, guys. If you've been on the show, you know the routine. You got to let me know who you are, where you're from, and what is in your mug. Hey there, Mark. Happy holidays. Thanks a lot. Oh, thank you, guys. Thank you. And we got Susan on board. You know Susan.
No, Susan. Look at Susan. I got a stack of your cards right here, ready to go. Look at that.
Oh, Susan's wonderful. Is Marshall with you, Susan? We got Bill coming in. Bill Flint from North Carolina says hello. So we got a couple. We'll have some Tar Heels on board today. That's awesome. All right, we got Emily coming in from Central PA. We got Devon. Actually, it's Damon. Damon, man, you got to change that tagline of yours. You always confuse me when you come on board. We got a lot of people that just jumped on real quick. All right. So Marshall is here. Good. Glad to hear it. And Emily's got her peppermint mocha. We've got John C. from San Diego as well. We got Scott coming in on board with all the saying thank you to all the veterans drinking his cold water. We got Jeff Zanny, man. That name sounds a little bit familiar. And Martin. Kind of. We got Martin coming in from Colorado with cold Modelo Especial with lime. Man, you guys are getting fancy. We got Tom. I got to meet Tom at the Gecko conference, which was so wonderful to meet you, Tom. And both Toms. We got my Canadian Tom and Tom from Maryland. We got Barbara. We got a full house tonight. Holy cow. They saw you coming, Dr. Flint. We got Trisha O'Neill.
We paid a bunch of people to come online.
Holy smokes, man. I don't know. I'm feeling a little intimidated here. Navy's going to kind of show up Army tonight, maybe. I don't know what's going on. All right, guys. All right, so we're going to get the show officially started. For those of you who are joining me for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. And tonight I have a very special guest, Dr. James Flint, naval surgeon extraordinaire, on loan to me from Integrum and from the U.S. Navy tonight. So big thank you for being here on the show. So guys, many of you know I have a very soft spot in my heart for veterans. My own father served in the 82nd Airborne for most of his career. So hoo-ah there to all my Army veterans. And guys, I do the show every year on Veterans Day. And truly, we can never say our thank yous enough. And when I scheduled the show at the beginning of the year, I really didn't realize I would be scheduling it the day after one of the most biggest elections in our nation's history. And the reason we have this freedom to vote and freedom to choose is because of our veterans and our men and women who fought for our freedom. So thank you. So for my veterans here tonight, please let us know who you are, where you served, how many years you served, so that we can thank you. And in the meantime, let's get the show started, Dr. Flint. I'm going to zip up for a while, and I'm going to let you do a little bit of the talking and tell us, please, a little bit about yourself.
All right. So go Navy, beat Army. I do come from a military family. So grandpa was Navy, dad was Navy, my brother and sister, both Army. So I do have a place in my heart for the Army. But yeah, I'm Navy. I joined right out of high school, actually. So joined via the delayed entry program. So I got kind of eked out when I was 17, signed the dotted line, joined when I was 18. And then 26 years later, here we are. Enlisted, wanted to kind of get out and explore the world a little bit before I went to college. So I enlisted, became a medic or a corpsman in the Navy, was with the Marine Infantry for a short period of time, deployed with them. This was before the war, again, 26 years ago. And then was fortunate to get picked up for college pretty quick. So went off to college, got back on active duty. After undergraduate with the University of Arizona. so, which was awesome. So met my wife, been married over 21 years now to my beautiful wife, and I have some family, I think, joining from Arizona too, which is awesome. And then, and then went back on active duty, went out to the East Coast for medical school and my residency training, did my orthopedic residency there. And then I went into general practice for a little bit down in North Carolina, which was close to some other families. So that was awesome. We got to see them more often. And then ultimately went to Houston, Texas for an oncology fellowship. So my specialty in orthopedics, even though I still do general and I do pretty much everything, trauma, sports, all that kind of stuff, my specialty is cancer, soft tissue sarcoma, bone sarcoma, and any kind of bone tumors, that kind of stuff. But my exposure in the military during OIF, OEF at Walter Reed and my training there was really all the casualties that occurred in Afghanistan and Iraq came through Walter Reed. And so my mentors at the time, really everybody that was at Walter Reed, but in the oncology field, some names that you might recognize, Kyle Potter and John Forsberg. And they taught me, everything I know, and it kind of developed a passion for oncology. And then ultimately came out here to San Diego. I've been out here 6 years doing my ortho oncology practice, where I'm fortunate to have a unique situation where I'm active duty Navy. I do all my active duty requirements. I see pretty much everybody. The way I describe it is kind of the Western hemisphere of the globe comes to me, and the Eastern hemisphere of the globe goes to my partner, Shannon Lorimer, out in Portsmouth. She's awesome. And then, of course, Walter Reed gets some folks as well. We've got Ashley Anderson, who's going to be, who's already kind of started up out there and is going to be coming back after fellowship to Walter Reed. And then really kind of got into osseointegration from there, which we can, if you want me to kind of go talk about that, we could do that now, but started developing integration practice as well.
Holy crap. So you're kind of an underachiever from what I'm understanding. That's incredible. Well, even though cancer-related amputations account for technically less than 2% of all amputations, you're going to find that here on the show we have quite a few cancer survivors. So let's see, we've got Jim Simpson. He's a U.S. Air Force, 26 years, retired, Scott Air Force Base. Sorry, no mug tonight, just not right from my single malt. That's okay. We've got Damon on board. There's another 82nd Airborne Division from Fort Bragg, North Carolina. That's my birthplace right there, buddy. All right, we got Jamie Dixon on board saying hello. Kim says she's a 5-time synovial sarcoma cancer survival here. Benny is our jarhead. He's our token jarhead. He had 4 years in the U.S. Marine Corps. So Semper Fi there, Benny. Let's see. Oh, they're just starting the questions already. So we got someone with Xylem, handles Xylem 98, saying, what do you think of the ongoing ivermectin trials for cancer treatment? Is that something you want to comment on, or do you want to go ahead and?
Yeah, well, in general, so chemotherapy in general, or any kind of trials, is really the realm of medical oncologists. So I'm an orthopedic oncologist, and my specialty is the surgical treatment of bone and soft tissue cancer. So I don't go into kind of the weeds of the specialty trials and stuff like that. I leave it to the orthopedic or to the medical oncologist for that piece. But certainly anything from amputation to limb salvage, any kind of surgeries like that, that's my realm and kind of where I keep my expertise.
There we go. And we got Jerry Ann in Arizona. She says, big veteran family, son-in-law's in the Army right now, and he's a command sergeant major. And thank you for your service.
Nice.
All right, guys.
Thanks for your service.
And thank you guys. Keep these comments coming, guys. All right, so tonight the show is sponsored by Integrum, and you guys who have watched my show know that Integrum is no stranger to the Cosi Talks hot seat. Osseointegration is something that we are seeing explode in the United States since it received FDA approval for the Oprah implant system back in 2020. And actually, we just had a very large osseointegration conference in Charlotte, where some of the greatest minds of the world for osseointegration came to this conference. And it was just incredible to see all these different surgeons, physical therapists that are on the cutting edge of this technology. So it's always wonderful to have another surgeon come on board and explain their perspective and their viewpoint and training. So Dr. Flint, when did you start getting into osseointegration with your patients?
Yeah, so I after my cancer fellowship, started setting my practice here, and because of my relationship with Walter Reed and my mentors who were out there, quickly became apparent that a West Coast version or a West Coast location for these patients to come was a need. And so I started actually patients I got into osseointegration really the way nobody wants to get into any practice, which is by handling follow-up patients or patients that were having complications and then just needed some help, or maybe they couldn't travel. Some of these patients came, had their original surgery overseas with other types of implants, things like that.
Right.
But for whatever reason, for travel or financial reasons, whatever, they just needed somebody they can come to. And having specialized in amputations and having just an extensive amount of history with amputations, this was kind of a logical next step. And and I was familiar with it through, again, Dr. Potter, Dr. Forsberg. So I started putting that together and offering osseointegration to patients because I do believe in the technology, and I think I see it changing lives, and I know that it changes lives in a really big way, especially for transfemoral amputations, transfemoral amputees in particular. So I started picking that up, and really, like I tell my residents here, I don't say no to much when it comes to surgery. So I like to be, welcoming and inclusive to, all the issues that people are dealing with amputee care in particular. So osseointegration was kind of the next, big step of taking care of folks, and there was a need there. So I picked it up, and it continues to grow.
Absolutely. All right, guys, I'm going to go ahead and do my tech thing. Y'all know how good I am with that. We're going to share the screen, and Dr. Flint has some really great slides that he's going to be sharing with us and kind of just talk us through. Now, you guys have known the basics about osseointegration, but again, repetition is the mother of memory, and it's always good to hear from somebody else. So without further ado, let me see if I can get this right.
I say repetition is the hallmark of adult learning.
There we go. I used to be able to say that in Latin once upon a time. All right. Is the screen coming through?
Mm-hmm.
Okay.
It is for me.
All right. So
there you go. Have to give my disclosure. Anybody in the military knows that we have our standard disclosure slides. So there it is right there. I'm not paid I'm from the government. I'm here to help. I usually use that as a joke. But I am from the government. My views aren't those of the government. My views are my own, and I'm not paid by anybody. I'm not paid by Integrum. I'm not paid by any osseointegration company. So I'm here to just give you my experience.
Cross the I's and dotted the T's. There we go. All right. So you just tell me, Dr. Flint, how you want me to proceed.
Yeah. So in general, the osseointegration, we can kind of go through, and I'll kind of tailor this towards the Integrum side. It's what we're talking about today. But there's a lot that kind of is involved with osseointegration. It's not just very straightforward. And I love this slide because it's a great joke of my practice in general in oncology. Nothing is easy, but we joke about we do it not because it's easy, because we thought it would be easy. But with osseointegration, there's lots of challenges, and not everybody is the ideal candidate. And so I don't always say yes to everybody. So it's important to know who is the right patient for it. What does that team look like? What does the surgery look like? And how do we manage the rehab and complications, things like that? So
there you go.
Just next slide, if you just in general, of course, we're talking about Integrum tonight. That's your screw type implant. It's really a screw type press fit implant. It is press fit in the sense that it's a very tight fit in the intramedullary canal, but it does have screws on it, and we do kind of screw that into place. And then in general, there's a group of implants that are out there that are press fit implants, which basically they're pressed into place very tightly, malleted into place. And there's lots of different implants that fit in that category. And then there's a novel compression type implant as well that is out there as well that some people will recognize.
Okay.
Indications of surgery. Really, for me, I feel like the future with osseointegration, for me as a cancer surgeon, is really anybody who needs a transfemoral amputation. I would love to set them up with osseointegration right away. What's nice about Integrum in that regard, it doesn't have to necessarily be Integrum, but what's nice about that is I could do the first transfemoral amputation and set them up for osseointegration, right? I could put that fixture in, the implant in, and then get them a regular implant. And if they do well from a cancer standpoint, we could then convert them quite easily to their osseointegrated implant.
Nice.
So I think that's kind of the future. You could also do that with a press fit implant. But the cancer sometimes plays a role if they're getting chemo, things like that. There's some options for that. But really the indications, the majority of patients getting it are in the trauma realm, right? Or maybe they had an amputation all their lives, maybe they're congenital or whatever, and they're just not happy. So at the transfemoral level, which is why it's FDA approved, is because it's so life-changing at the transfemoral level, is anybody who's not able to use a socket. So they have a short residual limb, or their soft tissue really isn't amenable to a socket. So that's kind of the biggest indication there. They have issues with their socket, or they're just frustrated with it. Sometimes I have patients will come in and they're like, well, I'm doing okay with it, but I don't really like how long it takes me to get up in the middle of the night to go use the restroom, or if they're a bilateral amputee, right? That's a huge deal. So just the fact that they could do it faster and less burden with that is a big deal. Sometimes it's, the liner that I have to put on is kind of ridiculous, and I sweat a lot, or I'm in, Arizona. I'm getting quite a few patients from Arizona now that, it's hot, it's sweaty. I don't like it. Would love to have my skin back, right? And so they just socket use. And of course, now it's convenient because Integrum is an FDA approved implant. So we can go ahead and just offer that right off the bat without having to go through the compassionate use process. Very easy.
Now we are technically obviously in the United States, it's only been approved for above the knee amputations, but we are starting to see thumb implant and above the elbow implants. And then globally, it's used in a wide variety. So we have the above the elbow, below the elbow, above the knee, below the knee, and the thumb and finger implants around the world where the Oprah implant system is being used.
You'll start to see some research coming out. I know Walter Reed, they've done a lot of the US trials, and data is coming out of Walter Reed, and you're going to see some publications coming up in the next couple of months from them, which is awesome. May include their transhumeral data. So they've got some transhumeral stuff, and then transtibial starting as well. So it's not FDA approved, to answer Ashley Martin's question. It's not FDA approved currently for transtibial, but I think in the near future it probably will be, and is available for transtibial via compassionate use. So there's many patients out there with transtibial.
All right, and then the fun part that we have to talk about is who is not necessarily a candidate for osseointegration.
Yeah, so everybody that comes it's not always a yes answer. There's lots of contraindications. The surgery, like I said, it's complicated enough. So if we get a little bit too risky, sometimes it can cause more harm than good if, we're constantly dealing with soft tissue complications or infections or things like that. And we have to be careful with that. So I think there's a balance. I think there's some folks on an extreme spectrum who are pretty limited in their indications of what they do. And then maybe on the other end of the spectrum, they're very liberal with who gets it. And I think there's a common happy ground. For me, anybody with an active infection, we got to clear that infection first. So I do have several patients that have fought with infections. We'll kind of deal with that, maybe clear out. Sometimes you even have to take out the hardware and start over. So anybody with an active infection, I'm not doing osseointegration on until they're completely cleared of that infection, and I'll usually test that and before I put any metal hardware. Anybody who's not controlled on their diabetes, anybody with really bad vascular disease, I think if it's well controlled, if it's kind of minor, not a big deal. Weight control can be an issue because if you're a little too far overweight, really, when you have to deal with the amount of force and stress that you're putting through that implant, but also still soft tissue complications as well that we have to deal with that. So I'm a little careful with that, and I do have some guidelines there. And then anybody that's active smoking, just because of the risk of soft tissue complications, and anybody really is using tobacco products pretty regularly, I'm very careful with that.
Yep, that's a big no-no. And then y'all have heard me talk a lot about the team approach, and this is not just for osseointegration. This is for all amputees. It really does take a village to get a successful outcome as an amputee, and even more so with osseointegration. So I love seeing this slide up here.
Yeah, and I think the next slide has my team. So I'm fortunate. Obviously I'm active duty Navy, so I work at the Naval Hospital, and that's where my initial patients came from. Where a lot of them were just follow-up patients from the Walter Reed and the East Coast. I just don't want to travel back there anymore. I'm pretty much done. Everything's good, but I need somebody who can follow me long term and maybe deal with kind of the longer term things that we deal with, like hardware maintenance, that kind of stuff, or if they're dealing with a chronic complication or something that just needs a little bit of attention. That's how that kind of started. And then I took it over, to the UCSD program too. So I'm fortunate to have a training agreement basically with UCSD where I can split my time between the two hospitals. So I have a civilian practice as well. And
Very nice.
with my partners there, plastic surgeons here. You can see Dr. Ortiz there. He's a plastic surgeon here at Navy. Yep. And then Dr. Chirapa to my right there, Dr. Reed is a plastic surgeon over at UCSD, and then just various folks that you see pictured here, orthotics, prosthetics.
Probably recognize this guy.
That guy right there. So it's a team approach for me. And a lot of the things that I end up dealing with, like I said, I kind of got into this backwards because I started dealing with the revision surgeries and the maintenance issues before I even did any of my primaries. Is dealing with those complications. So you really need a team. And one of the biggest problems that I see and kind of deal with are the soft tissue complications, especially when a plastic surgeon isn't used. So I'm a big proponent of bringing in plastic surgery. I could do, like I said, I could do the plastic surgery. I'm very well trained in plastic surgery techniques, but it's not the same as having a plastic surgery partner who's in it. And really their expertise is way above and beyond what I can bring to the table alone. So
absolutely. No, and I couldn't agree with you more. And actually one of your plastic surgery colleagues was on board, Dr. Susan. You guys, if you want to watch some of the shows there as well, you can go back to the YouTube channel and watch some of those shows as well. Ooh, I like this next slide. Tell us, guys, I do want to preface that there are a few slides on here that demonstrate surgical procedures, and I will try to give you a heads up if I see a particular slide coming up. So this next slide does show x-rays of how the bone looks. So take a look here.
Yeah. So the way I describe osseointegration surgery to patients, I'm the orthopedic surgeon. So there's some debate on, is it an orthopedic surgery? Is it a plastic surgery? What is it? Well, in general, the orthopedic part is, unless there's a complication, it's really a small portion of it. The soft tissue component and dealing with the soft tissue, the skin and the muscle and everything else is a much bigger part of this procedure and doing that correctly. So from a bone standpoint, if you go back to that last slide, it's really just, what do you have to work with, right? Is this somebody who has a short femur? Is it a long femur? On the left there, that's kind of ideal. If I get a patient like that, I'm like, wow, you're going to do fantastic. And a nice implant in there. It's gonna be nice and tight. Or if I have, somebody like our prior war casualty, something like that, where there's heterotopic ossification, there's hardware in the way, maybe it's a little bit more complicated. Do I have room for the implant, right? So I may need to revise that amputation to a higher level. So the bone surgery, it's a big part of it, obviously, and getting the bone to osseointegrate with the metal, and there's a lot that goes into it. But then from the soft tissue component, which I also do, it's a much bigger portion of it.
And there we can see some of that there. Going
in. The planning that goes into it. So I always template these out and kind of get an idea of, what does the bone look like? What are the cortices or the thickness of the bone? Is it going to support an implant? Would it be best to put in an integrum implant, which is the vast majority of what I'll do? But sometimes a press fit is indicated as well, or if it's outside the FDA indications, then you may be looking at that. And here's just a great example. It's threaded implant, but it's a press fit in the sense that it's a very tight fit into the cortex.
Snug fit into there. Okay. And then moving on to some of the soft tissue. So guys, with the Oprah implant, it is a 2-step procedure. So with the first step procedure, the fixture is implanted and then the wound and everything is completely closed and allowed to heal. And depending on the surgeon and the patient, it can be anywhere from 3 to 6 months of healing time to really allow that bone to fuse with the implant. So Dr. Flint, what is your time frame for your patients between stage 1 and stage 2?
Yeah, and I have a model I can show too when we go back to the big screen. But for me, the original protocol was 6 months.
Right.
And I thought, for my population, that's just really not acceptable. So
we're starting to see some
really
adjustments
fast,
there.
Right?
Yeah.
And so so the DoD program, osseointegration program, is for 3 months. But we're also a product of our last complication, right? And, I had one patient who 3 months was just not enough, and it didn't heal quite enough for me to be happy with the bone graft there. So I do 4 months, and I've been happy with that. So everyone's a little bit different, but yeah, 3 to 6 months, totally fine. I like to do that on the sooner side whenever possible. For me, it's really at 4 months, and then getting them to walk a little bit faster too than the typical protocol, so that people can stand and kind of get back to their lives.
No, and it was interesting just even at the conference this weekend where we're starting to see, some of the original protocols that were brought in 2020 for weight bearing, and we're starting to see those modifications done as we're learning as we go along. So
Everybody's
that's kind of
different.
cool to see that.
Yep. And so here,
Yeah.
here's that model I was telling you about. This
Yes.
is a courtesy of Integrum here. So when I present this in clinic, I'll usually bring this model in. And so this is just a model of a femur, transfemoral amputee. And what we're seeing here is the fixture inside the bone. And then this is the part we're talking about. This little area right here is what's bone grafted. So we'll put the fixture in place and then bone graft. And so it'll look like that at the end. And so all this material needs to be bone grafted in, because this is where the skin is going to be sitting, where you basically have, excuse me, a soft tissue skin graft essentially sitting right there. So that's stage 1. And then we'll do a primary amputation closure over that. I'll usually do a thigh-plasty during stage 1 with my plastic surgery. So I do a thigh-plasty with each stage, or if it's one stage, then we'll still do the thigh-plasty and then come back and revise it later if we have to. And then stage 2 is putting the abutment in, which is this little piece here. And so that's what the axle or the connector attaches to, and that goes right in, connects to the fixture in there, and then there's a backup screw. This is a press fit, so that does get pushed into place, and it's tight. It's a tight fit, and the screw just backs that up. And then we just tighten the screw and we torque that up as well. And at the end, your skin would be attached to the end of the bone here. All of this should be sticking out of the skin. If you don't do this properly, maybe you have a little bit, not enough metal sticking out, or maybe you have too much metal sticking out. Problem as well. So you really got to be careful in your surgical planning, which is another issue that I see sometimes, to get that just right. And then your axor attaches right here, and then you walk straight off of that.
Off you go. So, Julie, a thigh-plasty is basically plastic surgery for the thighs. So it's taking all that extra thigh tissue and trimming it up, because what we don't want is for all that soft tissue around the thigh, whether it's fat or muscle or everything, to droop down over that implant, because then all that skin will get chafed and skin abrasions. So what doctors like Dr. Flint and will bring in a plastic surgeon to help basically lift all those soft tissues, and almost like a facelift for your thigh. That's basically how it's done. And we see that, as you mentioned, sometimes you do that in stage 1, and also sometimes later on in later stages. So yeah, it's truly incredible to see some of the pictures of these thigh plasties and how they can really lift that soft tissue up beautifully. So let's just kind of review a couple, because when I'm sharing the screen, guys, I can't see your comments, so I do apologize. And if we missed your questions tonight, this evening, guys, go ahead and keep reposting them. Let's see. Pat Glover there saying, drink tonight is ice cold Brooklyn lager and pewter running mug. 82nd air. We had a lot of 82nd airbornes here tonight.
Well, was that right. That the Army thing? Yeah.
Yes. All right. So let's see. Ashley was asking about the transtibial, which you grabbed that question. We've got Earl from California. A little gal called Jennifer on board as well. Let's see. Robert says, I got 2 surgeons also scheduled that day. One is a plastic surgeon. Yep. And Gail says she also had a revision of the soft tissue in March. So as we mentioned earlier, you said the first stage of that procedure, the fixture goes in, everything gets closed up, anywhere from 3 to 6 months, depending on the patient. And then in stage 2, I'm going to go ahead and share the screen again so that we can see how cool this stuff is.
And some good slides of why the importance of the thigh-plasty.
Yes. Yes. Okay. So
if I have a patient comes in, if I have a patient comes in looking like that, I'm pretty happy, right? It's a really good looking leg. The soft tissue is well done. On the left, there's actually an example of a patient that I did that we were able to prepare the leg ahead of time. So this is after stage 1, just did a nice amputation and really set it up well for stage 2.
It looks nice and tight.
On the right, you can see this is a patient who's been in a socket for a very long time.
Yep.
You can also see the difference in these 2 patients. The one on the left has all their quad muscle, their hamstrings, because this is a new amputee that we went straight to osseointegration on that patient. Whereas on the right, this is a person who's been in a socket for at least a decade. I think it was closer to 2 decades. So you see that
the atrophy.
You get a lot of atrophy, but it's still a good, well-shaped leg, and I could do a lot of good work with that. But what we'll find out later, and we could even talk more about, is the amount, because of the amount of muscle atrophy that is done in these chronic amputees. It's really a workout to get osseointegration, and it can be like going to the gym every day. You get that muscle ache every day because you're using muscles you haven't used in a very long time.
Yeah, and we say this at the time. You know, when you're in a traditional socket, you're not weight bearing through the end of your bone, and a lot of your soft tissues are being compressed, so they cannot contract as efficiently. So definitely, definitely getting much more of a workout, but you have also a much more beautiful gait pattern, and more efficient gait pattern, I think, with the osseointegration. But that's just my personal opinion.
Yeah, I agree. So those are the ideal. You know, if I see somebody comes in and with that leg, I'm like, yes, this is going to be great. And then, unfortunately, sometimes I deal with these kind of patients that come in and say, hey, what can you help me with here? And this is where thigh plasties, are important. So when you're dealing with so much soft tissue, you could just imagine on the left, just even to put a socket on that.
No, this would be very challenging.
So osseointegration is a great way to bypass that soft tissue, but you still have to manage that soft tissue. Otherwise, we kind of get in a situation like you see with these other two, where the soft tissue and the fatty tissue underneath are just hanging over, and when they go to sit up, it can be sitting on the implant. So we'll have to come back and do a thigh-plasty and just do some plastic surgery, cosmetic work to get all that up off the implant.
Right, and then we see
something doing that ahead of time, right, and just doing that at each stage, like the way I do it, or prefer to do it. You don't have to do it that way, but it just prepares the soft tissue a little bit better.
Absolutely. All right, let me kind of go over here.
Yeah, and this is just an example of the different, why the soft tissue is so important, because on the left is what we say the screw fit or the integrum model of osseointegration, where the end of the bone is basically a split thickness skin graft. There's no fat underneath that skin. So we're going skin to bone. And if we can get that to attach very nicely, there's no motion at the end of the bone. And there's no motion on the implant, which is great. We get less drainage, and that's ideal. Whereas some of the challenges that we see with press fit implants is sometimes the soft tissue is too thick at the end. You get way too much motion. It's not really attached to the bone very well. So there's a balance there if you're going to do press fit, or if any of you have a press fit or have seen that. I think there's a balance there, and we're starting to see that as we talk more, like at the Gecko conference and all these worldwide conferences. We're seeing that, and surgeons are responding to that. So
Right. And I would say, like, in our show, we've talked a lot about actually the main differences between screw fit and press fit. And the biggest differences is screw fit, obviously it requires the 2-part procedure, but also how the opening is handled. From a soft tissue standpoint, where the abutment comes out looks very different in a screw fit compared to a press fit. I'll go to this next picture.
Yeah, okay. So that's kind of a good outcome, right? We want to minimize the motion. You see that the skin is very tight to the implant there. That one healed up really nice. Sometimes you'll leave the operating room looking like that, and then after some time moving and starting them in therapy, it pulls away a little bit. So it's not always perfect, but that's what we aim for. And same on the right is a little press fit implant. Same idea. We're just trying to get stability of the skin implant interface there. And then
more pictures here.
Great pictures of what a stable aperture looks like.
Yep.
We call it aperture, skin penetration site. Different names for it.
Okay. And then there's obviously different rehab protocols for the different types. With Oprah, there's a little bit more conservative management with weight bearing. So they wait a little bit longer to allow that bone to really fuse. And then with the press fit, it's a little bit of a faster weight bearing protocol. And then we have, unfortunately, sometimes we do get some soft tissue complications that can be involved. And this is something that we talked about in previous shows. Not this one. Actually, this is pretty cool because is this a video? Oh,
yes.
Hopefully we can see. Oh, good. Definitely one of the benefits of osseointegration is that's all you have to do to put your leg on, and you are done. So for those of you who are my above the knee amputees, obviously you can see that takes a lot less time than having to put on the liner, the socks, the socket, suspension system, and everything else.
And this specifically is the Axor device. So that's an Integrum device. That is a quick connect, for Integrum specifically. There's different attachments.
So guys,
Attachments.
And we don't like to talk about the complications, but it's something that needs to be spoken about, guys. And I've done several shows on some of the complications from OI because this is an invasive procedure and it's not meant for everyone. So if this is something that you are thinking of doing, you need to know about what the complications could be, and more importantly, what questions you need to be asking your potential surgeon. So Dr. Flynn, I'll let you go ahead and talk a little bit about that.
Yeah, no, exactly. I think most, at least I would hope, osseointegration surgeons will kind of discuss what are the possibilities. Soft tissue complications, number one, and some surgeons would even go to say, what's the infection, for example. Well,
Right.
almost everybody at some point is going to get an infection, usually superficial. Usually, it could be just erythema and some cellulitis, or it can be a bigger problem and involve the bone and things like that. But some of the more common things we see, some watershed areas, especially when you're thinning out the skin so much, you can do that. Usually there's not much to do for it and you watch it. And here's an example of somebody who went on to heal very nicely with that. But sometimes you have to deal with that. Excuse me. And then the next slide, I think, just shows some, infections, and if the skin isn't super tight to the underlying bone, you can get some what we call hypertrophy, or some
Hypergranulation.
granulation tissue, or it starts to pull away if it's not balanced right. So lots of different things to deal with. The goal is to get to that stable platform.
Okay. Oh, I like this picture.
Yeah.
Nice.
So, especially my population, highly active population. And most people just want to kind of get back to a higher level of activity than they're used to with the socket. And for the most part, we can do that. There are some contraindications too, as far as, I had one patient come in, he's like, well, I want to go back to, wading through swamps and doing this kind of stuff. It's like, well, osseointegration is not for you. Okay.
No.
Clean water. Okay. Swamp water. You need a socket.
Not so much. Yeah. Absolutely. So guys, we're going to give Dr. Flint a chance to catch his breath for just a moment, and we're going to do one of our famous or infamous giveaways here. All right. So you guys know I love my giveaways, and I'm making it as easy as I possibly can for you. So guys, start scanning this QR code with your phones. And in the comments section, I want you to tell me at least one benefit of the Oprah implant system. And when you scan this QR code, you'll come to this beautiful page that gives you a lot of information on the Oprah implant system. And again, while we understand that it is not meant for everyone, it is something that I think everyone should know about and have conversations about. And if you feel like this is something that you're interested in the same place where you scan this code, there's just a little information form where you can just kind of send in your information and someone can contact you just to answer more of your questions. All right, guys. So this one is going for a t-shirt. Y'all know we love our t-shirts here on the show. So give me a comment, and I need to switch back to my comment section. All right, as to what are one of the benefits of the Oprah implant system, and we will pick a winner. Actually, we're going to pick two winners tonight. We're going to pick one for a t-shirt and one for a $25 gift card. So start putting it in there right there. Let's see. Gail says, I had both the press fit and the screw fit. Love the screw fit because there's no drainage. And that is definitely something I see and hear a lot in just comparing the screw fit and the press fit, that there's less drainage coming from the aperture. Dr. Flint?
Yeah, and I think that's a technique thing too, right? And so the biggest difference is with Integrum. I think I had another model here too, but with Integrum, the diameter of the abutment that's coming out is pretty small. So the hole where the aperture site comes through is smaller relative to the press fit. But regardless, you can get stable platform there as long. I see Colin Jackson there. You're amazing. The press fit is a little bit bigger, so getting a stable platform is a little bit more challenging, but there's ways to do that. And so I think that's kind of the bigger issue.
Absolutely. And Gail says Dr. Forsberg did mine. Yeah, actually, finally met Dr. Forsberg last weekend at that conference.
Yeah, he's awesome.
Yeah. Let's see. Jenny said, I'm late, but finally made it in. Oh, there we go. So she's one of our wonderful Integrum ambassadors right there. Okay.
I guess the benefit for osseointegration for me is being on Cosi Talks Live tonight. So there we go.
Oh, nicely said. Nicely done. All right, guys. We're going to be picking a couple of winners here. Sorry, I got to check my cheat sheets, make sure we got everything on board right now. All right. So Dr. Flint, I know you mainly work with cancer-related patients, and are these usually active duty members in the military, or are they reserve or retired at that point?
The majority of osseointegration patients are not cancer patients, so it's pretty rare in
Okay.
the cancer field. So I do trauma work as well, and any amputee can come see me as far as osseointegration. So anybody interested in it that's in the neighborhood or can travel, or I'll consult on osseointegration as well. It's really just to have another system in place here in Southern California and the Southwest where people can go, because there's very few centers in general that do it.
Yeah, no, absolutely.
Yeah, so
Now,
it's really trauma is my most common.
most common one. And then I ask this of every physician, surgeon, clinician that comes on the show. If someone is interested in getting osseointegration done, what are the questions that they should be asking their prospective surgeon?
What's your experience with osseointegration? Are you going to be retiring anytime soon?
Yes. I mean, we laugh, but that's a real thing, because this is
not, osseointegration, it's so specialized, and it fits well in a cancer practice, in my opinion. I'm biased because I do cancer, but I'm used to following patients for a very long period of time. So this isn't just a do the surgery, put in the hardware, and then wash your hands and good luck with that. This is, we're in it for the long run, and we become long-term friends, patients, and many of them become friends at this point because of the amount of time that we spend together, just dealing with life and any complications that may come up, or just tweaking the prosthesis, or getting them to work just right, strengthening their muscle. The physical therapists are a big part, and the rehab part of this is huge. So it's kind of a family. So yeah, I would ask, what's your experience with it? Are you going to be around long enough, or what's the, what does the team look like? If it's just one person and they're just doing it out of a interest in doing it, maybe I'd think twice about that. For me, like I said, I'm biased about having a plastic surgeon. You don't necessarily have to have a plastic surgeon, but does that surgeon have plastic surgery techniques, and do they care about soft tissue? I think is really important part of that. And is it right for me? What are the things that are, every patient's unique, right? So I can't, even though I have this indications and contraindications, I'm not just saying, oh, tick, 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 that's done, you're the person. It's really, what is my sense of, is this patient going to do well? And are they really committed to it? And there's a lot more to it than just checking off some boxes of yes and no.
Yeah, I think my favorite question to ask is, what do you feel like osseointegration can do for you that you cannot do now with the traditional socket? To gauge as to whether or not this is a feasible procedure. Now, we have a lot of folks that travel, right, to have this procedure done. And I imagine you have your fair share of out-of-town patients that come in to see you. How, and I'm asking this because I see this a lot on the Facebook groups and the chitter chatter on the groups. How do you manage your patients once they go home? If they have any issues, if they have any complications or questions, how does that work?
Mm-hmm. It's difficult.
Yeah,
especially
no.
here
And
in Southern California.
sure.
At least one patient who does not live in this country, and travels up for follow-up care and things like that. And he's a particularly tough individual. So I'll see you when I see you, which makes it easier. But really goes back to the team concept. So if I have patients from coming out of state, which is typically from Arizona, for me being here in Southern California, is finding the local resources there, and expanding my team to not just the team here at UCSD, not the team here at Navy, but who's the team in Arizona that can then follow up, which is mostly a rehab team. So physical therapists, occupational therapists, prosthetists, and who are the local prosthetists. As well as, are there any other surgeons in the neighborhood, which are starting to come online. So there historically wasn't anybody in Arizona, but there is now. So, and it's a friend of mine, a colleague of mine, so I can refer there for follow-up if needed. So it's really just trying to develop a database of who are my people, who are the contacts. So if there's an issue, they have immediate access to care, and then ultimately they can come back to me for that follow-up care if there's a big issue from a surgical standpoint. So it can be challenging, and people do travel back and forth, and it can be a challenge, but really identifying the team, I go back to that.
Yep. And guys, I put the onus just as much on the medical team, but I also put the onus on the patient themselves. You have to be your own advocate, and you also have to be responsible for your own care. So when you meet a surgeon like Dr. Flint, who's very open and upfront about this is what's involved with this procedure and the commitment involved. Like I said, unfortunately, we've seen on social media sometimes where folks were kind of left in the lurch. And a part of that, definitely the responsibility falls on the surgeon and their team, but it also falls on the patient to say, okay, we don't want to think about the worst case scenario. We don't want to think about complications, but if those do happen, what is the plan? So that's something I definitely encourage folks to say, okay, what is the plan if this happens? What is the procedure if this happens? Who do I get in touch with? Who's going to be following up with me at these points? Because, we need to have that set in place. All right. So we've got our first winner for the giveaway, Robert Clubb. You are the first winner. So Robert, congratulations and thank you for participating. I am going to be putting my email up there. So Robert, what I want you to do is I want you to email me your address and your t-shirt size so that Integrum can send you the prize. And guys, for those of you who are new to the show, this show is for the amputee community. So this is amputees, clinicians who serve them, family members, and caregivers, and our advocates. And if I don't have the answer, I will go and find someone who has the answers for you. But that is my email address, and you are more than welcome. In fact, I encourage you to send me your questions because this is how I know what you want to hear about. So feel free to send me your questions to my email there. All right.
I could see. Yeah, there's a lot of questions. I'm actually going to look looking back on here too. And
please.
Robert Clubb actually asked a question. So one a prize and asked a question. But if we go back to those, if you want.
Yes, absolutely.
Age limit. The original protocol for Integrum specifically was a cutoff of 65 years old. So typically that's, relative indication and a cutoff. I've done this in patients who are right at the threshold. But for me, I will consider it for those who are physiologically younger than 65.
Yeah.
So it really just depends, but a relative number would be 65 that kind of sticks out off the bat, especially if you're looking at Integrum. The FDA approved indication is for less than 65.
Right.
And then Robert Clubb's question was putting weight on the bone. Does that cause a loss in bone density? Actually, it's quite the opposite. So bone responds to stress.
Yes.
And so that's the benefit of osseointegration is that you actually bring the bone back into it. So when you're in a socket, you're actually bypassing the bone and you're really stuffing the leg into a socket and you're relying on muscles and a soft tissue platform that doesn't work very well to walk and to ambulate with, and it requires an incredible amount of energy expenditure. When you bring osseointegration into it, you're actually bringing the direct connection of the leg back into the bone. So the bone gets to respond to stress. It's something called Wolff's Law, where the bone responds to stress, and it actually builds back up over time. So your bone density becomes much greater, and you get to see that over time on x-rays.
And that's actually, I think, one of my favorite benefits of this procedure. There's actually one of Integrum's ambassadors. Her name is Mary. Absolutely lovely individual. I don't know if you had a chance to meet her. She carries around in her purse a 3D model of her femur, which is literally just this big. And the long story short, she spent 30 years as an amputee, above the knee amputee, very short, really unable to use a prosthesis because it was so short. So when they went to do the implant, the bone density was not great, and they were able to implant her. And 2 years later, I think it's been 3 years or more, you can see on the x-ray it's thickening. Her bone is getting thicker and stronger, and I stink at reading x-rays, and even I could see that right there very clearly. And then the other thing, guys, is when your prosthetist is fitting you in a socket, we've talked about it, how your femur is kind of just flip-flopping around in that socket. And it's not kind of anchored down well. It's really challenging to anchor down that femur and get a nice stable fixation. So that's another huge benefit with OI is basically they're just taking the implant and boom, it gets put into that same angle as your sound limb. So again, from a mechanical standpoint, it just gives you that much more efficiency when you're walking. So that's where my nerd flag goes really high. Let's see. Lori is asking, is it recommended for someone who has very small bone canal?
Careful. I do consider it. So it depends on, how small we're talking about. I have some experience with this. Try to be as vague as possible.
Okay. Yep.
yes, it can be done. There are limits. So with Integrum in particular, there's the smallest implant. So there's a relative threshold for how far. I think it's 14 or 16 is the smallest implant.
Okay.
But you can remount the bone if you need to. If the cortices are thick, you can get there, or you can do a custom press fit for a small canal as well, which is an option, and just do a custom design to the patient. My biggest concern with very small diameter canal is what is the cortical thickness. And so if the cortex is nice and thick, and the canal, the intramedullary or the middle soft portion, what we're talking about,
Where the bone marrow sits.
Where the bone marrow sets is here. This is your cortical weight-bearing bone, and the middle is just marrow. My biggest concern with that is, do I have enough grip with the cortical bone to support the implant? And if they have very thin cortices and a very thin, a small bone, then that could be problematic, and we need to be careful with that.
Mm-hmm. All right, and then now we're getting all the questions coming in. All right, so Bree says, thanks for posting live with us. I'm a hip dysarthric amputee. All right.
Mm-hmm.
And then
Carol
we have
Davis talking about the UCSF team. Love the UCSF team. I am friends with all of them, and I know exactly what you're talking about.
And I don't know if you've had a chance to meet Carol, but she's absolutely one of the most beautiful people you will ever meet. Like, seriously, Integrum has some of the best ambassadors.
And Houston, the Houston team as well, depending on who did her surgery. But
yep, I think Dr. Doherty is out in Houston.
Mm-hmm. Okay.
Yep. Yeah. So we got, let's see, Tom saying currently a patient of OI above the elbow, 1 year in and doing great. Friday, I go in for OI on my femur. What is your opinion on the new transdermal compress system?
The new transdermal compress system.
I think he means the compress Zimmer.
For compresses system that they have. Yeah, not a whole lot of people doing it yet. I think the majority of it is being done out in Philadelphia. Some of my colleagues out there, or in Pennsylvania.
And Johns Hopkins, I think.
Yep. And so I love compress. I do compress quite a bit in my cancer practice. I have not done any osseointegrated compress, mainly because it wasn't available there was a time period where it just wasn't available. So I'm excited for that to become available. It's the indication for that really can be anything that you want, but it's very useful, in particular for people with very short residual limbs. So with compress, you could, depending on the anchor plug and there's kind of technicalities of it, but you could do that with very short residual limb, which is a nice option to have with that implant. So you're going to get into the same issues with, a little bit larger skin aperture site. And so really paying attention to the soft tissue platform is going to be important for that, as it is with every system that is used. But yeah, I love compress, and I'm excited for that to come online and be another option for patients. Like I said, I'm an equal opportunity osseointegration surgeon, so I don't really say no. I'm happy to work with any implant, and I'm very thankful to have FDA approval for the transfemoral. It makes that a lot easier, and the Integrum team is fantastic, and
they really are great
throughout the nation. Very easy to get the follow-up care that you need, the prosthetics, and they do a very good job at that.
All right, guys, we're going to do one more giveaway. I'm going to throw up the QR code again. And this time when you scan the QR code, I want you to tell me the name of one of the ambassadors that you're going to see on this particular page. All right, so go. And this one's for a $25 gift card. So get going, guys. All right, we had one question here. There's Mary. Okay, Mary, thank you so much. So she was the one I was telling you about that had the very short femur, and she said, so just over 41 years. Holy cow. And Mary is amazing. She walks so beautifully with that osseointegration. Let's see. Randall's asking, what would be the youngest person for osseointegration?
Well, if you believe what you see on TV, when Grey's Anatomy, which was an Integrum implant, I talked to Dr. Brennemark about that. They would tell you.
I didn't see the show yet. I haven't seen the show yet.
Yeah.
What was
it?
Funny. Was it a young patient?
So I didn't watch the show myself. I was watching because my wife was watching, and she watched the show, and she's like, "Hey, I think it was a 15-year-old, and this is going to be as an amputee. Like, they're talking about our amputation. It's going to be osseointegration. I just know it. It's I just know they're going to do it." And sure enough, it was, and it was osseointegration, and it was the Integrum implant. So I talked to Dr. Brett about that, and he had some fun with it, and got to go out to the set and everything. So, but don't believe everything you hear. The FDA approval is not for 15-year-olds, although that it could be a very nice option for them, but it's all adults. You have to be an adult.
Yeah, and basically, it's basically the growth plates, waiting for the growth plates to mature. So Dave is saying the Integra ambassadors are the best, and they really are pretty amazing. So Xylem 98 is asked.
That was Mary Schultz you were talking about?
Yes.
And so she has a very short residual femur still, and
yeah, it was tiny, and I remember she was one of the first ambassadors I met, and she's absolutely the warm personality. And she's like, "Yo, here it is." She has her 3D implant, just that she carries around to show people, and in her case, she's an incredibly active woman. Was I believe, kindergarten teacher, if I'm not mistaken, and having to get around without a prosthesis for all those years because, as you can imagine, with such a short limb, suspension was a nightmare. So yeah, she's an incredible story.
Some people get lengthened first, and then they'll do it. It's harder with the muscles to do that, so there's some limitation to that. Or go with the short femur. I certainly have some patients like that, and so the challenge with that is there's not much muscle, right? And so you're still using quite a bit of energy expenditure, better than pocket. But they can be a challenge too, to kind of rebuild that muscle, and you'll see that over time, which is kind of cool. Even on an X-ray, you can see the muscle developing.
Yep, absolutely. Okay, let's see. Tom says I only have about 4 inches on my femur bone as well. Let's see. There was one question. So Xylem 98 was saying I wasn't able to catch on the weight limits for a patient to qualify, but was the weight limit solely based on weight, or do they take BMI into account as well?
That's actually a good question. Yeah, it's an individual talk with the patient. They're 100 kilos is what we kind of talk about in general. I'd like patients to be below 225 in general, but sometimes there's just big folks, right? And they're muscular. They're not necessarily, their BMI is okay. So I will consider it. We'll talk about it, and we'll talk about what the challenges might be, with just being heavy and putting stress on an implant. So it's not just a direct cutoff, but there are some, relative contraindications based on weight.
Okay. And I was just informed that Jennifer FT is the winner of our $25 gift card. So congratulations.
Congrats.
So Jennifer, when you get the chance, please email me your address and we'll make sure that we get you that gift card. Holy cow. We covered a lot of material tonight.
Still going.
Yeah, we are still going. All right, guys, we are going to go ahead and let Dr. Flint have dinner with his family because he came off a very long day of work. But we're going to go ahead and cap things off here. Oh, so Dave's saying he's 6'4" and 240 and doing well with osseointegration. Mm-hmm. Yeah, Dave has been amazing with that.
Yeah, perfect. Where it's again, you meet with the patients and you talk about it, and everybody's a little bit different. So we talk about it regardless. And for me, my approach is, and I'm happy to stay on a little bit long. I mean, I'm happy to.
No. Keep going.
Yeah, I'm fine with that for a little bit. I'm sure my wife will forgive me. All right. And then I'm looking at Robert Club 2's motorcycle ride redundancies. Yeah, and so there's safety protocols built in for, especially with Integrum. They have some torque limiter, basically.
Yep, and flexion. Yep. So they have a flexion release. So basically, if you flex it too much on accident or do a sudden rotation, the axor kind of just releases. So it doesn't put that rotational and flexion forces into the implant itself. And it's a little bit more of a protection against fractures. That it was actually interesting. It happened like the gentleman I was telling you at the conference that I was doing exercises on the ground. When he got to the ground, that the safety mechanism was activated and he was able to put it back himself, which is kind of a nice perk with the OPRA. So if the safety mechanism is activated, the patient's able to reset it on their own.
The bigger concern, if you bring up my slideshow, I have a picture, periprosthetic fracture. So my biggest concern with motorcycles in particular, I'll get on my soapbox about motorcycles, is has nothing with osseointegration per se, but motorcycles in general are just orthopedic fracture machines. So if you break something at some point, right there. So there's that's slide 47.
Okay.
Right there. So there's an example of that wasn't from motorcycle riding per se, but you can get fractures, and it's usually from people falling. So fractures can occur, and we'll treat those just like any other fracture. So my main concern with motorcycle riding is the fail-safe going to engage, and is the implant going to be okay? It's mostly, are you going to break something that we then have to go fix? So,
Yep.
Dr. Brennemark and Tigrum in general, and some of the contraindications, or not contraindications, but some of the relative lifestyle modifications, is really not running and doing high impact stuff. People will do it, and my population will kind of push the limits. Especially, I'm used to that. But
especially the military.
If you're gonna get osseointegration, I'm gonna say probably best that you're not running. You do better, especially as a transtibial. If you go into sockets, you could run on sockets. I'm not going to really worry about that too much. If you do osseointegration, I'm worried you're going to break.
Yep. And I think when Kurt's been on the show, he's mentioned that if somebody really is a runner, that they can use a traditional socket for the running part, and they just have to make an accommodation for the actual fixture and abutment. I have yet to meet someone like that because I kind of want to see what that would look like. But yeah.
Gina Thomas seems like my kind of people. I hate running too. I'm a 0.0 kind of person.
She's a yoga gal. She has the most amazing Instagram channel under Slim Ginny. I love recommending it because she really just shows how far you can take the OI implant, and standing on her head and doing all sorts of really crazy, awesome things.
Bike, bicycle, swimming. There's so many other things you could do. Rowing. Come on.
See, well, that's where Army comes into play. We just run. That's what we do. We keep running all the time.
Reminds me of Colin Jackson if he's still on. I don't run, but I'll walk with anybody as far as you want to walk, but I won't run.
Let's see. Lori says, rules me out because I ride horses. I think that could still be done.
Yeah. No, horses, I mean, not necessarily.
Yeah. All right. Holy cow. Well, I think, Dr. Flint, we're going to go ahead and wrap it up for this. The swimming limitation. No. They keep the questions coming. I told you. Last man standing.
They're gonna keep going. Yeah. Swimming limitations. Not really. So the swimming limitation really pertains to the type of water that you're in. So if I've got a really good seal on an osseointegration implant, like I just showed you on the slideshow there, you have a picture of the patient in the water there. That's clean water. So in general, clean water, saltwater pools, regular, chlorinated pools, all that kind of stuff is fine. You don't want to be in murky water. Honestly, San Diego water is not where you want to be.
No, but I mean, if you just think about it, it's kind of like common sense. Even with two anatomical legs, there's certain water you just don't want to get into.
Yeah. So. Patient who wants to go diving, and I'm not in the business of I'm telling you what you can't do, but I'll caution you about the things that might happen if you do. So swimming is okay, water's okay. You have to be safe about it. I like to create, my prosthetist here creates silicone caps for the end of the implant. So you can do a silicone cap and put like a custom suit over, which kind of just limits the amount of water and stuff that you get into. But I certainly have dealt with complications of people getting in the water as well and getting infections based on that. So it's, it goes back to what are the risk benefits, and I've told one patient in particular, like I said, if your business is getting in swampy water, then I'm not doing osseointegration on you. You're going to come back infected.
Yep. Something to think. Yeah. And then Ginny says, I swim pools and the Gulf. I've even been to a lake. I apply Vaseline to the aperture before to act as a barrier, clean well after, and no issues. And that's what, some of the protocols will say. We'll put a little Vaseline there. And in some cases, some folks will put a little Baxitracin or Neosporin just to kind of coat that area, and then cleanliness afterwards. That's definitely when it comes to the hygiene. But again, those of you using traditional sockets, hygiene for the socket and the skin there is also a part of your regular routine. So Van Gregory, he's kind of a badass. Van Gregory, he's my bilateral below the knee. And he says, why no running? So why is that a contraindication?
Yeah, because of the torque involved with running and the impact, there's just a higher risk that you can get loosening over time, or that you can cause stress fractures that lead to completed fractures. So it's just a relative. Do people do it? I'm sure they do. Just don't tell me about it.
Yeah. No, and then the thing is, guys, when you're running, you're putting 8 to 10 times your body weight into your joints. So even when you have regular anatomical joints, and I'm a runner and I love running, I'm addicted to it, but it's a pretty hard on the human body in general. Let's see. Xylem says, does having that implant affect having tests like CT scans, ultrasounds, or MRIs?
Nope. So you can do all that. And depending on what I'm looking for, I'll see that. MRI is going to be a little bit murky.
Okay.
Metal, you can get an MRI, not a problem. The problem with MRI is that because there's a metal implant, you get metal artifact when you're looking at an MRI. And so anything that's really close to the bone, it's hard to interpret. If I'm looking for, say, an abscess or cellulitis or something like that, it's totally fine. CT scan is totally fine, and I'll usually do, if I'm looking for infection or abscess that might involve the bone or things like that, CT is where I'm going to go most of the time with that. So yeah, you can get all that.
All right. I'm like waiting.
The other thing, my question for the crowd, and
Uh-huh.
kind of turn this, if I'm putting in the chat, is what are you doing to clean your site? I know what I would do if it were me, but I think people are kind of all over the place with what they're using. Some are doing kind of natural remedies, some just do soap and water. I got one patient who has had the best outcome, barely ever follows up with me. I see him maybe once or twice a year in passing. And he says, "Oh, I'm doing great." I was like, "Well, what are you doing to keep?" Nothing. Soap and water.
Soap and water.
I've got another guy who walks on the end of his implant. I mean, some of the crazy stuff I see, and they're doing great. And so it's all over the place. But I'd be interested to kind of consolidate. I think there's a NIH study or survey that's kind of been out of what people are doing, and that's what I'd like to see, is what people are doing.
And it's interesting. So guys, Cosi poll, those of you who are on here, thank you, Dave, for posting that. What do you do to clean your aperture site? And that is it's funny, like people will ask me a lot in terms of just cleaning their liners of traditional sockets. And I'm always of the bank of saying, don't use the antibacterial stuff. Granted, I'm talking about, and I'm like, because you're killing off all the good stuff. And I go, guys, gentle soap water and rinse. So let's see. Jeannie says, I use DermaCleanse most often outside the shower, regular soap and water otherwise. And I also use HIPAA if I've been in questionable environments. Mm-hmm. And I think that's actually the most practical way of doing it. Save the HIPAA for the stronger need. But yeah, that's very interesting. And they had a lot of talks at that Gecko conference that we just had in Charlotte about, what is it that they find if they're culturing that area, and what's natural and, what's just going to be endemic to that area.
Don't see a whole lot of alcohol use, alcohol swabs, things like that. I'd probably use that on the metal, to sterilize the metal, which would be nice.
Yeah.
Some people, lavender oil, so kind of natural remedies too. So lavender's good. Melaleuca is good for antimicrobial properties. So.
Yep. Or diluted tea tree oil would be another.
Yeah, Melaleuca tea tree oil. Yep.
Melaleuca. Yep. All right. Said Robert says, with surgical scars, I always use non-perfumed soap and guess this would be best for this. Yeah. Keeping it clean. Mm-hmm. All right. Holy cow. This has been a good show.
Yeah. It's been fun.
It has been. Yes. All right. So guys, I think with that being said, I think I'm almost scared to say we're going to wrap it up because I think about 10 more questions are going to pop up. But guys, I did put my email site there. If we did not answer your question, or if you think of a question after we close the show down, please feel free to send me the email and I will get the answer from Dr. Flint or from Integrum. But I do, again, want to say to all of our veterans there, I know it's a little early, but I want to say happy Veterans Day, guys. And thank you so much for your service. Thank you, Dr. Flint, for your service and for serving our military men and women, and also for coming on the show and giving us a little bit of your time this evening. We really appreciate. And thank you to your wife and children for letting us have you for this evening as well.
Yeah, no, thanks. This has been a lot of fun. And I share that sentiment. Thanks for what you do. God bless all of you. I thank you for your service and for the sacrifice of those who are veterans' families and have served. And if you have any other questions for me, if you're in the neighborhood or know somebody's interested, you could just Google Dr. Flint San Diego and you can get my contact info. So
we're going to post that. We're going to put that in the post section, guys, as well. All right, guys, as always, thank you to Integrum for your continued support of the Cosi Talk Show and with your amazing Oprah implant system, changing so many lives out there. Guys, show my sponsor some love. Go visit the Integrum website and give them a shout out. So in the meantime, guys, thank you for letting us be a part of your lives this evening. I will see you next week, same bat times.